आप अब जाग रहे हैं ना? ओके, नींद सबको आ रही है। सब लोग जाग रहे हैं या थक गए हैं? बस करें?
I want to hear you talk.
Oh, okay.
Even if it's alone, I will listen.
Okay. No, it's like I won't spend too much time on that. Third space endoscopy. So these are my disclosures. जी?
थोड़ी सी लाइट कम कर दें तो
नींद अच्छी आ जाएगी।
मुस्तफा and I can sleep.
मेरे हिस्से पे नहीं होनी चाहिए लाइट।
बिल्कुल ठीक है ना, उधर से शाइन भी ज़्यादा होगी। So this is a presentation I gave a grand rounds at one of the universities. So that was like 45 minutes to 50 minutes presentation, but I only plan to spend 15 minutes. Especially Dr. Sajda is saying like she doesn't have that much time. Okay. So what is third space? Third space क्या होती है? A potential space. GI tract में third space कौन सी है? किस space में किस wall is है ना? Mucosa, like muscularis mucosa, submucosa, muscularis propria. फिर based on depending on if you are in the chest, it's adventitia, in abdominal cavity serosa. So which one is the third space? Submucosa itself, basically. Yes. Submucosa means third space is inside the wall, somewhere. What's the first space? What's the first space? So why we ran straight to the third one? Endoscopic. That's the first space. And what about the second one? What's the second space? Surgeon space. So beyond, like first space is intraluminal, second space is extraluminal, and the third space is inside. So this is like I'll just go through. In 2007, this concept of like ESD itself was invented in Japan 1990s, and the reason for that is to resect superficial cancers in the stomach in one piece, because there is a very high incidence of gastric cancer in Japan, so that's where it was invented, to have a minimally invasive way to get rid of those tumors. That gave a kind of working in ESD with the with the submucosa, that gave kind of an idea and gave a little bit more comfort. Maybe you can work in that wall. So this is Dr. Sumiyama from Mayo Clinic in USA. He came up with the concept of mucosal flap valve. This is, I think we were talking earlier as well. Like you create an incision, get into the submucosa, and to talk about like submucosa, you can expand as much as you want to. You can put a scope, you can put a other, as much as you want to expand, it can get expanded. So they, they did in animals, got into the submucosa, and then went down through the submucosa, cut the muscle, and then came back and closed the entry point, and then washed those pigs for a few weeks. And then they didn't get infection. So they came up with the idea, like if you can close this entry point, and then maybe you can work on the muscle which is outside to work on these achalasia disorders and stuff like that. So that's where this concept came. And then somebody actually did in like myotomies a year later, pretty much same. Actually, this one published in 2007, but done in 2006. Then somebody did on these myotomies on animals in 2007, and then eventually the first case of POEM was done by Dr. Inoue in 2008 in Japan. He's a surgeon himself, so he's the one who did the first case of POEM for achalasia using the same concept. So with that, ESD, as I said, 1990s, notes. Anybody knows what notes is? Natural orifice. Natural, yes. So surgery, we were very enthusiastic that we're going to take everything away from surgeons. We're going to start doing gallbladders, appendectomies, but that was taking quite a bit of time. I think laparoscopic was much easier. So there was a lot of enthusiasm in the beginning in 2000, but that has gone way down now. And because we're better off working inside the wall than outside the wall. There's some work still going on outside the wall, but the majority is being done inside the wall. And then stir. Anybody know stir? G? And endoscopic resection for leiomyoma, GIST, and those ones. So that came along. And then G-poem, gastric poem. Actually, the concept of gastric poem, actually Ali Rahman published first. He was the first one to publish in Animals, the gastric poem. He's one of our friends, Pakistan se hai, but he works there. So he published that first thing on the animals, and then it was done in 2013 in Johns Hopkins. That was the first G-poem, gastric poem done. And then PRAME is for rectal for Hirschsprung's disease. Then Z-poem, I think, I wish we had a Zenker, but Z-poem is like for the Zenkers. It's more cumbersome than doing a septotomy endoscopic. Endoscopic septotomy literally takes 10 minutes, and all the ENT surgeons send their Zenkers to us now to take care of that. And then diverticular poem, like with these patients develop esophageal diverticulum, we can do we can cut those diverticula by going into the third space as well. And then now poem F, it's a fundoplication. So it's being done in India. They're doing quite a bit of cases, not universal yet, but all this poem halar myotomy, which is done surgically, they do a door, a partial fundoplication with that. That's why patients who undergo halar myotomy with a door fundoplication, they have a less risk of reflux after halar myotomy than the poem, because usually we don't do a fundoplication with poem unless, but if over a period of time it gets better, and if it doesn't get better with the medicines, you can always do an endoscopic treatment of that. Okay? So now third space, I mentioned that it's been being used in multiple GI dysmotility disorders especially. And with regard to poem achalasia, I won't go over those. You guys know type 1, type 2, type 3. And there are other motility disorders, and we did 2 poems anyway today. Eckhart score, you guys know that as well. It's a score which is based on these 4 symptoms, really to identify the severity at the stage of achalasia, and also identify or measure the effectiveness of treatment. If you do some therapy, be it endoscopic, surgical, and if the final score is not less than 3 or less than 3, that is not considered an effective treatment. So why EPOM is so successful? All these achalasia, especially at least, all these disorders have an EG or GE outflow obstruction. And it has shown a consistently high clinical success rate for all types. So basically, I'll show one of the randomized trials which really pushed the poem to the point like now it is a first-line therapy. And you can see it is, as an endoscopist, once you you know how to do endoscopy, it is teachable, it is learnable. So it's not difficult. So this is a achalasia, classic achalasia type 1. There's a category 1, type 2 and 3. Category 1, these are those different types of achalasia. And then type 1, 2, 3, they all have a G junction problem. So that myotomy needs to go through the G junction. But there are other, like a diffuse spasm, jackhammer, there is G junction is fine. So you really don't need to cut a G junction below. You can do just all the way to the GE junction, but not cut through the GE junction. So I had, I left my laptop in the hotel room. I didn't think I was going to give the presentation. So I had all those videos embedded in this presentation. We have to pull it up from my OneDrive in my hospital, which did not have a video. So, but you have seen, I don't think I need to show you the video of poem. You saw 2 of those. So this is that randomized trial. I think it was published in, when was it published? 2019, I believe so. And this is a poem versus laparoscopic halar myopathy. The idea of this was like poem is non-inferior, basically, to halar myopathy. That's how it started. 221 patients, similar numbers in both arms, poem versus halar myopathy, bid door, and 2-year follow-up. And if you look at the results, it's actually in poem, at 2-year follow-up, I think it's close to 83.5% as compared to halar myopathy, 81.7%. So it's not like a retrospective study effectiveness. It's like a randomized trial with a 2-year follow-up. No, that's what I was. They thought poem is going to be inferior. That's how they started. The trial was put up as a non-inferiority. So they like it's not inferior. They didn't say it's a superior. Yeah. So that's how it was. So what they showed is at least equivalent in this one. And but it still, there was some favor by 1.4% towards poem. Biggest issue with the poem in this was, actually that I'll show that later, but the biggest issue with that was reflux. Almost 59% of the patients in poem, they developed reflux, especially at 30-day follow-up, as compared to 29 or 30% in halar myopathy. But over a period of time, that difference started decreasing. And after 6 months, majority of the poem patients, they were fine on 1 daily dose of and there was not much difference left. Comparing poem with pneumatic dilation, that's what we mostly have been used in the past. Randomized trial. Here, the poem 6 to 7 patient and pneumatic dilation 6 to 6. All those bars really, they're showing the number of patients. If you look at these bars, these are all, and anybody at active score of 3 or below that, they were considered successful. So all the poem ones are there, and with the pneumatic dilation, not many patients had that kind of a response. So at a 2-year follow-up, really it was that poem was much better as compared to pneumatic dilation, which was like close to 50% response rate, and in this one, close to 90% in poem. So this is another study from New York, 10-year follow-up on 610 patients. The biggest thing in this study was all type of achalasia patients in there, different. The most common is type 2, 50%. Then is type 1, then type 3. There were all type of these patients were in this study. Half of those patients actually had some sort of prior treatment, either a pneumatic dilation or halar myopathy or previous poem trial. So it's not like a simple patients. They included every single patient. Some of those patients even had a mega esophagus or sigmoid esophagus. That is going to call like when it's more than 6 centimeter diameter. So in all those patients, all types, combined efficacy and effectiveness was more than 90% at a 10-year follow-up. Some of those have 5 years, some of those have a 10-year follow-up. Multiple now studies have shown that the poem efficacy average at 5 years is 90% or more. Okay. And then I think there's some, this is what I was talking about, the same trial showed that the one which was randomized POEM versus Haller, 57%, 20% at 3 months, and then 44 versus 29% at 24 months. So majority of these patients could be treated effectively with the
These
PPI.
results, sorry, to interrupt, this is patients who are taking medicines or not taking medicines?
These, I think they, after POEM, they put everybody on medicines. No. These ones actually, I don't know. I think that when they had the reflux, they started putting them on medicine. So I don't know exactly. I need to take a look at the paper, like if they really were put on that from the very beginning or not. So how to limit that? If can we do something to make it better? One of the options is like just cut the GE junction. Don't have to cut all the way down like 2-3 centimeters. Just 1 or 2 centimeters should be fine. And then there are sling fibers. They are towards the, when we do the posterior approach towards the fundus, that's where they are, sling fibers. And if you cut them, there's a high risk of reflux. And because in Haller myopia, mostly it's the anterior area which is cut. So those are mostly safe. Maybe that is one of the reasons as well. And with the wrap, there's a less reflux. Then there are these two vessels called the perforated vessels. We didn't, if you go deeper into the fundus or a little bit deeper in towards the cardia, you would see those, and the goal is to cut the G junction towards the right of that. And they have shown that decreases the risk of reflux as well. Okay. And then anterior and posterior approach you already saw. Really no difference, major difference. There may be some evidence that the anterior may have a less reflux as compared to the posterior, but really not a major difference. If these do develop reflux, then you can do an endoscopic or even surgical fundoplication of these. And it's been not only achalasia, other spastic disorders, you can use it for that. Kind of already mentioned the overall success rate more than 90%. Peds, we do get Peds patients as well, actually. We do a home on these children as well. And yes, for the prior failed treatments or even prior failed POEM, you can repeat it. So that's pretty much on patients are.
Good, but I took different questions, so just want to read this.
Narcotics. The patients who take that, they develop some sort of dysmotility. They may have a high IRP manometry as well. Bottom line is like patients on narcotics, if they develop a dysmotility, we should make every effort to get them off that before we consider any sort of treatment. And this is our study actually from our center. POEM utilization in US, it's been getting better. It started in 2008, came into US around 2010, slowly picking up. Pneumatic dilation keeps going down because it's not that effective. I think Haller going a little bit down, but not much. Still, majority of these patients still end up going through that. This is not my video. This is actually, I hope it works. So this is a video from Dr. Bappai. Do you know him? He's from India. So he does these after the POEM. What they're doing is like they are going into the, they cut the, do a full thickness myotomy, go into the peritoneal cavity, and then find the fundus area to make a wrap of that. So it's endoscopically being done now, and now it's like we are working in the peritoneum there, you can see. And then grabbing that, this is kind of a fake wrap they do first. grab that fundus and bring it and see if that's the really area where they should be grabbing it. And then they mark that area, put a clip on that, bring it out, put an endo loop, bring it out, and then just attach that to the myotomy site. So it kind of makes making a wrap that with the clips and this endo loop. It's been, according to them, it's been maintaining, I think, a few years of follow-up, and it's working out. Gastroparesis and G-form, I think you guys discussed about that earlier, right? No? Yes. Okay. So I'll try to skip that then.
What's your experience with PREM?
With what?
PREM.
Haven't done it, and the same group is doing it. They have done few cases, and they think it's a really good results. But for that, they have to do a myotomy starting at the anal sphincter, and just all that dysplastic area segmented just like that. I think. So this is actually the G-bone. You see this ring? You saw that being cut. That's a pyloric ring. Same way you do like tunnel 4 or 5 centimeter before the pylorus on the greater curvature side. Just keep tunneling. It's a little bit becomes a little bit challenging when you get close to the pylorus because it's uphill. So there's a tendency to cut inside the muscle as well. So just gotta be careful. But once you see the ring, you know for sure that it is a ring. And then you just cut the ring. You don't want to extend that cut into the antrum, because what happens if you cut the antral muscles, which are propulsive, they are the one which push the food out of the stomach. So if you do a longer myotomy on those, you're not helping the patient. So only thing need to be cut is just the pyloric ring. And we did this study, we presented at DDW as well. We were doing a endo flip to check the pressures in their diameter on these patients pre and post. Like do one right before you do the same session, do this first, endo flip measurements, and then do a G-form, close the tunnel, and then do another set of measurements, see if there was any difference, and then 3 to 6 months later. So what was the first, both sessions, first and second measurements, which were pre and post right after, really didn't have much difference. But some of the patients, those who have a distensibility index lower at the pre-one, like during that when we did the form, they had a better response as compared to those who have a high distensibility index. Okay. So that was one of the only factors which determined that if patients have a lower distensibility index, possibly they are the one who can have a better response to the G-form. Okay. I'll just skip that. Z-poem, I'll just show you oh, I don't even have a video there, so that's what I wanted to show actually, septotomy. Septotomy is much easier. If you look here, this is a septum, esophageal lumen on that side, the reticulum on this side. We have this scissor cutter now at night. Not that it cuts with itself with the mechanical force, it cuts with the current, and we just put that scissor, grab that scissor knife, grab that here, and just keep cutting. You have seen that, right? And keep cutting. It literally takes 8-10 minutes, and you are done with that. That's good. No, that's not the scissor. That's a regular knife. The picture, but I had a video.
With the scissor, it becomes.
And it's like you're not cutting it mechanically. You just grab it, hold it, apply the current, and pull it back.
It's not sharp.
No, it's not. It's a current.
It's a current based.
Actually, there are two of those. It's called a clutch cutter. I brought those. I thought, yeah, there would be some case I can show it, but. I think I'll just. This is the one we were talking about that crane, sadly. So this is from them.
So because
This is their video for us.
where is Bob?
He's in
South India.
South India, I think so. And this is a star. Closure devices. Anybody has seen an X-Tack or no? आपको इधर है नहीं पड़े हुए लेके आया था मेरे ख्याल में maybe they are in
No,
there.
we have that. Yeah. Sorry.
Have we used it? Okay. So that I really love that. That's my most favorite closure device, and it's just a suturing. You put 4 tags, 1, 2, 3, 4, and just close it. Again, sorry that my presentation is sitting in hotel room, which has the videos. And then these are not third space, but a couple of different things. Kambi's our colleague, he works on these unusual things. So this is a patient with a gastric bypass. It's got a candy cane syndrome. Like they have the blind pouch is quite long, and they just keep vomiting and vomiting. And then you see that this is a blind pouch right here, 5 vein, and there's a large septum. So what he did is, this was the first case actually done endoscopically. Nobody had ever reported this before. And so they put a suture here, this is a like wall, this is a blind loop, this is the actual lumen. Put a suture right on that. As I put a suture on this side all the way to the base, the suturing, and then make it like a septum, and just cut the septum to that. And the patient who was on TPN for 1 whole year started eating in a week, and I never had that symptoms again. And then this is another one. We did presented at DDW. This actually got a Best of the Best award as well. So this is these are perforated duodenal bulb ulcer, and they have a surgery. They have a mental patch, don't heal. They have a second surgery, don't heal, and then third surgery is not possible. They're already so bad. So those kind of patients, like failed surgical, what we did is we had done like 7 cases so far, 7 or 8. And what we do is basically create a gastro EUSGJ, and just like we did, Mustafa did today, to create a lumen, and then close the pylorus completely with the suture. Yeah. Yeah, gastrojay. So endoscopically, and then bring them back 6 weeks later, and open the suture only pylori. Put a contrast. If it has not healed up, then resuture it. But if it has healed up, you can remove the axial stent, and that closes up.
So there is no external drainage of the duodenum there?
Like the one, if they have already, we'll leave that.
Yeah.
They usually have the external drain, but it comes out where, like in a couple of.
Need an external drain for the patient because it's intubated pancreatitis patient.
So in this one, yeah. So in this one, yeah, it is. So in this one, the majority of these patients, ulcer is proximal to the area of. Even then, some yes. I think they all had the drain. You're right on. Yes, endoscopically. See, I told you surgeons don't like us. Okay. Anyway, so I think that's pretty much. Oh, before I do it, this is our team, by the way. This is where we work. Isn't that beautiful? So that's this. Yeah, they all are our hospital.
The picture on the right or the left, which one are you talking about?
Okay, I'm talking about in the background. So we are in this building, and you see that lake? You see that lake from our unit.
And the
We-
place where they eat
So do you get time to enjoy that lake?
No, not from our offices.
Yeah, not from our office.
Not from our endoscopy.
and yes, they don't have any time to go and look at it. They only look at it like when they're showing these pictures.
Exactly.
Then they realize, oh, they have a lake outside.
Yeah, but it's a very beautiful place. Yeah. Okay. This is the actually third largest hospital in the in U.S. It's a 1,600 bed hospital. All those buildings, but 1,600 means 1,600 patient rooms. They are not wards. Okay, so with that. Yeah, it's like a third largest in United States. We have one more, now there are 7 of us. We have a staff of 45 on the nursing side and then almost 30 on other office side, so a staff of 70 people, not 150%.
So this is only for endoscopy?
No, it's just a whole hospital. Yeah, everything in there. Thank you.
Thank you.
Oh, and I want to remind everybody about Orlando Live, if anybody could come for that.
Okay, thank you very much, everyone. With this, we come to end of a very exciting and very, I think, fruitful day. So we managed to do how many cases, Asim? I've lost count now. Like 7 cases? Yeah, so we managed to do 7 very interesting cases. Okay, so it was like 12 cases, and out of which we were managed to do 7 successes. Yeah, because you were the one. Because the 3 that we didn't do were because of you, actually. Okay, so, but we did have very good discussions on them, because this is the practical situation that you see when you are dealing with such cases, that you go in with an intent to do something and you end up, not doing that thing, because that's not in the interest of the patient and the disease itself. So thank you very much once again, and really grateful to our national and international faculty members. Thank you, Dr. Saad Khalid Niaz, for coming with your foot in the plaster. So before we wrap up, I would like our international faculty and Dr. Saad to give final comments before we can close. Dr. Khalid.
People sitting in, especially at the podium, all moderators, everybody have a different ideas. We listen to those ideas and we tell them they are all are great ideas, but this is what we're gonna do. So just do the right thing for the patient. Just consider every patient as your own relative. What would you want for them? What is the best way? Whatever you do to the best of your abilities. अगर आप कुरान को भी पढ़ें तो एक आयत है, उसका तर्जुमा है, अल्लाह ताला कहता है कि सुस्ती की तरह ना, सुस्त लोगों की तरह ना बैठे रहो. Keep work. The work means like whatever assignments you are given, do it to the best of your ability. Allah is working himself too. So that's what basically the uska jo tarjuma ya translation hai. So this is like treat every patient just like at your relatives. But that's one thing, and other thing is thank you for having us. We really appreciate it. We always enjoy coming to Pakistan, this is our country. This is how if we can give anything back, this is, I think this is the best way for us to give, or at least we think this is the best way for us to give back. But you guys are providing us opportunity. So this unit is providing us opportunity. This unit has talent in form of people, in form of everything, equipment. So maybe not everything the latest here, but you're doing your best. People are doing their best to get the latest technology and trying to pass the skill on to the next generation. So thank you so much. Okay.
I think that was a very good point about all the experts sitting on the at the podium and giving their advices. I think it would be best for everyone to do what they are comfortable with rather than to take up a new idea and try that in a conference. So do what you are comfortable with and what you are good at. Dr. Mustafa.
Thank you, Nate. It was an excellent sort of day of cases, and I think, I don't know if you counted Dr. Hassan's ampulectomy not case or a case, because actually that case showed the value of EUS in those situations, getting samples. So just because we want to cut a polyp off and we don't, doesn't mean that that's not a case. So that's number one. Number two is, if in doubt, select EUS ERCP cases because you'll get to do them. So I got to do all of those, and that worked out well for me. But jokes aside, I think it was an excellent workshop. And what I find most fascinating is how much we learned coming back here and how to do things in a cost-effective manner. Because we are very spoiled, and we have way too many resources, and we use things without even thinking twice, open up another wire, do this, do that. But how to do them in a cost-effective manner. And then what are the things that make a big difference in a patient's life? So for me, because I'm a pancreas-focused person, I really sort of like to look into things that improve patient care from a pancreatic standpoint. So seeing the S-wall unit in a GI sort of unit is like a dream come true. Then seeing those cases being done. And actually, I don't know if you know our person with the beard who helps do the S-walls, Asad. So he asked me yesterday, and he actually called a few patients, and 2 of them came. And I met with them today, and I spoke to them about their disease, and they're both, mashallah, doing great. Pain-free, one is stent-free, one has stents. One lives, it's really interesting, it's sort of a reflection of life. He's married, but his wife is from Quetta. So, but he's from Karachi, and he's a rickshaw driver. And she asked me, तो फिर हम क्वेटा चले जाएं? मैंने कहा जी आप ज़रूर जाएं. कहती जी मेरा सारा मेका उधर है, तो फिर मैं इसको साथ लेके जा रही हूँ. So how tables have turned in life. So they're going Quetta, and then वहाँ कहती है कि और अगर दर्द हो तो क्या करें? मैंने कहा आप कॉल करें, या क्वेटा में भी हैं डॉक्टर. कहती नहीं, एक्चुअली हम क्वेटा से भी 6 घंटे आगे रहते हैं. So this is the reality of life, that this is the value of the service that you guys are providing. And that just touched my soul, because these patients are 14 hours away, they're coming by public transportation, getting the best quality care in this unit. So thank you for the service to all of you. And thank you for having us. Just keep up the good work. For Hamare liye to it's an honor to come here. We really enjoy ourselves. Thank you.
Thank you very much, Dr. Mustafa. It's really amazing, awesome, and very encouraging that you people really think about coming back and giving back to back something to your country. So that's really, really great. So, Dr. Farooq, your comments.
मेरा तो ये घर है. So I'm really here every 4 weeks. And I think it's really always exciting to be here. You guys are very lucky to have such an institute. I didn't have it when I was at your age. So I had to step out of my comfort. You didn't have to. And this is a real big thing. It really is a real big thing. Make use of it. We will always be here. मैं तो खजूर से ज़्यादा ही here हूँ. I'm here every 4 weeks. So, but I must admit, coming to Dubai has made that difference for me. I'll Lahore, Karachi, everywhere. I'll just leave in the morning. I do whatever I need to do, teach whatever, and then home, go and sleep in my own bed again, the same day. I feel myself very lucky really to be in that. I wanted to do it all my life, just never been able to. Because whatever, if you're in UK, you can't really do it every 4 weeks. And that, but now, the other thing is you guys have always welcomed us. It's not about what I want to do, what you guys are really happy for us to be doing this. So really part of you, and really pleased to be part of you.
Thank you very much, Dr. Saad.
I think I'd first of all thank Khalid and Mustafa and Farooq because it's, and Riyasa was here from Lahore, Shahzad was here. Obviously Pakistan se aana is a different thing, but these two coming from US and they are here every year. And we have learned so much. EUS at least, whatever we do, the credit goes to Khalid because he's the one who actually taught me. So, and then that's a big step. So whoever is learning and whatever is happening, Khalid has got a serious share in it. It wouldn't have been possible. So, I'd like to thank you all for coming. You're like family. They're all part of our international faculty, but it's not easy to come. So thank you very much on behalf of everybody. I also want to thank Nasir Saab and Mansoor and Arif, Abbas Saab and everybody else, Afzal, for coming and actually, you know, hopefully benefiting. I think short cases, but the cases that were done, I mean, 2 poems, gastrojejunostomy, EMRs, pseudocysts, you know, and so we've seen quite a, and in some interesting EUSs as well. That's great. Then I have to thank, starting with Dr. Sajda and Dr. Nawal Asim, and then the fellows, Nasir and Abir, Asma, I don't see her here, our anesthesia department and our staff, everyone. I think it's not possible to do something like that, you know, getting the patients and especially with my foot the way it is, I've not contributed a lot. So I think a big applause to all those who actually made it possible. Sorry, I forgot Shanil. Sorry. Shanil is sitting there. Shanil has been the mainstay of organizing and liaising with everybody and very quietly doing things. So that's why इतनी खामोशी अच्छी नहीं होती, कभी कभी नजर आना चाहिए. making sure you guys are working. And last but not the least, Government of Sindh and those who have supported us to create this facility, which I hope will provide training and obviously service. So thank you, all of you. Thank you once again.